We don't need to be given something. We need to invest in something. Do you want clinicians taking care of patients, or do you want to move the patient? It's a fundamental question we've got to ask as communities.
That's a good question, Doc.
So if you needed blood, you got an $85,000 bill. There is no emergency plan if one of those boats was having an issue.
Tune in for today's episode of the Leadership Lab, Clarity Special Edition.
Hey, thank you for joining me for another episode here at the Leadership Lab with Asbel Montes. This is our special edition series that we filmed live at our 5th annual user summit in beautiful Laguna Beach, California. But we actually had the theme Data, Doctors, and Leadership Through the Eyes of the Patient. And so to that point, Dr. Darsey, it has been a while.
It's been a while,
since
brother.
we've got to see each other, and he is a fellow Southerner, so I'm really excited about this. I'm going to let you introduce him, and then I'm going to tell a little story or two about us that he probably doesn't know yet. But Dr. Darsey, introduce yourself to
Hey, I'm Damon. I am a recovering paramedic and a recovering academic physician at a big major hospital. Long-standing in this field, but I have had a passion for pre-hospital care, specifically rural care, and for almost 20 years, and have now taken my clinical role out of the big Taj Mahal and taken it to a 5-bedroom emergency room in the middle of nowhere, and surrounded by my paramedics, and we are slowly challenging the norm in a very small part of the state.
And you're in Mississippi.
Mississippi, right? And, we often joke, we lead the nation in every category, right? Literally every category. That's a good thing or a bad thing. The good thing is, where else better to change? The bad thing is, it's a lot. Why go and talk about congestive heart failure in the Northeast? Interestingly, I had Harvard come down to do a trauma study on rural medicine the other day, and I made it my mission in life to show them really what we do. And they called back about 3 weeks later and said, "We don't understand what you're doing there." And I said, well, what we're doing here is we're trying to make people live in a place that it shouldn't matter where they live geographically. The healthcare should be the same, at least when it comes with an ambulance. And so it's fun to be in that environment again. I was in their medical world where you and I crossed paths a lot previously, and that was great. But I needed a world that really was challenging to something that we can do better in. And I found a niche, and I stay behind the scenes, except when I come to do things like this, and you drag me out here, and behind the scenes is kind of where I like to be.
Yeah. And so, Damon, this is the one thing that I want people to understand, because you mentioned Air Medical. That's where I met you for the first time.
Right.
You were working on a lot of things there. You were really doing some work with the Association for Critical Care Transports. And the one thing that I always liked about was you were a disruptor. You did not tell people what they wanted to hear. You told them what they needed to hear. They may not have agreed with you, and they could have argued against it, but I liked how you did that.
Yeah.
And I'm a disruptor by nature as well. And so when I found out that you were going into rural healthcare and you were doing some stuff there, I'm like thinking, okay, this guy will transform things. He's not afraid to do things. And so I want to talk about that. I want to talk about that pivot. You went from air, you went to rural health. That you're doing this in Mississippi, very, very rural area.
It is.
Very area that has a lot of underserved areas. You've got the Delta.
I've got one county that I serve that is the most desperate poverty you've ever seen. In the same exact county, it's the most wealth you've ever seen. There is no middle class. And so you have this dichotomy of wealth and poverty in the same area. Their healthcare shouldn't be different.
So let's tell a story, because you're a storyteller.
Yeah.
You've seen a lot of stories without violating. Tell us a story about how it's different in these areas, like that you see in some of these rural hospitals.
So the quality is so variable. The EMS quality is rampantly variable. The patient cohort and the sickness is some of the worst I've ever seen. And then for the jokes, you have the overall factor, which is you're a closed guy. If I've got a guy that comes in with overalls, he's automatically sick. It's almost like the sixth vital sign. So it's a language that folks are using in this environment that is completely different than urban. And what is so frustrating at times is looking at medicine and hearing all the urban things that come out of whole blood, for instance. It's the new sexy thing, right? Well, that doesn't work in rural America for a number of reasons. Component therapy, I can do a lot more with. I can do a lot more with 3 types of blood products versus just one. And what we're finding is the rural healthcare folks, the patients, are a lot sicker, are a lot less resourced, and that societal determinants of health that everybody keeps focusing on, we live it. Quite literally, we live it every day.
Okay, so we are so pivoting here. We had an outline, but we're deviating it from it now. You just talked about everybody's focused on the blood products, things like that, and you're like, we need different things in rural healthcare.
100%.
Talk to me about that, because that's going to resonate.
Yeah.
Because there's people that are, I mean, this is like this whole blood is kind of the premise of why I think physicians need to be leading, because they've done some things here.
Yeah, so don't hear me wrong with that. So I'm on the Blood Services Board of Directors in my state. I'm very intimate in the blood supply and donations. And what we've done in our little small state is we said, you know what? We know 3 things in rural America. I need blood for sickle cell anemia, a huge crisis in my state. Not emergent crisis, but a crisis. All my donors are urban. And we didn't have blood donation. We didn't have blood delivery in our state at all, except for the helicopter. So if you needed blood, you got an $85,000 bill. And you only got it 40% of the time when they were flying. 60% of the time, they don't come in our state for a lot of different reasons. So now we have people on the side of the road that need blood, and I could use whole blood, which is awesome in the Mecca centers across the country. But guess what? There's not a hospital in Mississippi besides one surgeon that uses whole blood in the hospital. So now I'm going to waste the whole blood. So I can't waste blood in rural Mississippi. I've got to use it or give it back. It's such a valuable resource. So we've developed a rural blood program that's given 18 months. We've given over 60 patients blood transfusions, and we've only wasted 1 unit. 1. And in the meantime, we've got at least 500 new donations of blood into the system to help with our other needs in blood delivery. That's not an urban concept, right? They have the ability. They have the gun and knife club. But what's also been interesting, I'm not academic anymore, so can't publish this stuff, but we've yet to have a physiologic normal, abnormal laboratory value on arrival with a patient we've given blood. Less ICU stays, less transfers, and it's not just trauma. It's GI bleed, postpartum hemorrhage, it's all those things that are out there. And that's coming from a rural perspective. How do I do it on the cheap, on the cost? And guess what, Asbel? No one's paying for it. Not the first payer is paying for it. So what we've done is we've gone out and raised money.
So have you met with the payer plan? So you've taught, and they just are...
It's the concept in our world in rural America is move the patient, get paid. And it's coming from EMS agencies. It's coming from our own kin, right? And that's the thing. And in rural medicine, what people don't understand is as soon as they leave their community, for whatever reason, pneumonia, dialysis, they get on an ambulance and they get transferred to a big hospital, they never return. They never return for any of their health care. Because the bigger hospital systems, at no fault of their own, network integrity.
Sure.
Build a network, come. Well, most of our patients either don't have transportation or can't drive or don't want to go to the bigger cities for whatever reason. Crime, traffic, bad food. Mississippi's got bad food, right? So we have all these things. And so what we're finding in rural healthcare is how do we bring, in the rural hospital environment, how do we bring the specialist to the patient? And what does that look like for economy? But it all starts with that 911 phone call.
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblackink.com.
So let's talk about that. I want to pivot because you're talking about rural health, and this was a part of the One Big Beautiful Bill and this rural health transformation. Now,
Absolutely.
people will debate it and say, well, you're taking money out of the system and you're only putting $50 billion into it.
So
Talk me through what you're doing that's transformative.
The beauty of this is, how do we do things that are sustainable? And what I tell everybody when they're looking at this money is, do a 2-year project, sustain it 3rd year, prove it 4 and 5. And if you don't do it in 2 years, stop the program. It's things like, everybody's talking about treat in place. And that's awesome. And there's a lot of really bad legislation that's come out for that. We've had some other people have had some. It just doesn't make sense. And Asbel, the reason it doesn't make sense is there's no quality associated with it.
What does quality look like to you, Doc?
Quality needs to be more than response times. It needs to be outcomes. What are we doing? Every heart attack patient I see in the emergency room, I have, don't quote me, 6 or 7 different quality metrics I've got to follow, right? Strokes, sepsis. Why are we not extending it to the field? Give you an example. Something I didn't think would make a big deal. Heart attack, type of heart attack, STEMI, 60 miles from the hospital. Our guys get there, they recognize it. We have a conversation. It's very important. Not that I don't trust my medics, I do. But let's have a discussion. Beautiful STEMI in a farmer with overalls on. The decision was made to bypass 4 hospitals, 2 of which had cardiology on the website, which is what a lot of people use to see what services are there. And we give every single drug, Asbel, every drug, besides one. I don't have IV pumps, but interesting enough, after this call, I got them, or getting them. Every drug, when they got to the hospital 60 plus miles away, they had a large Widowmaker MI. They spent 12 hours in the ICU. They spent less than 30 hours in the hospital. And I did a very conservative number savings on a post, LinkedIn, I think it was, of what that dollar savings was. And what was even more fascinating was the troponin, the heart attack enzyme, was normal. Because we got him there fast, we gave all the drugs. And the only drug we didn't give that the Taj Mahal Cardiac Center was going to give was drug I needed a pump for. Right? And so I look at the billing of that, and so that billed out an ALS1 after all that work, all those decision points. The whole concept of medical decision making that was there. I was involved, we were involved, we had dispatchers involved, we had patients involved, families involved. It was that complex decision making that we in emergency medicine get paid for that saved probably over $150,000 in true cost. And I got a guy out with a normal echocardiogram with a Widowmaker heart attack 69 miles away from the hospital. Didn't need a helicopter. Didn't need a small hospital. I would have loved thrombolytics. If I could have paid for them, I'd have given them, but I can't pay for them right now. They're too expensive. Nobody reimburses us. That's the kind of health care that we can drive. What's interesting is after I made the post, 3 of the managed care program people called me to tell me more. And I told them more. I said, you're paying us the ALS1 rate for a significant decision that was made. I made a pretty big liability on the phone in the middle of the night, rolled over and looked at EKG to confirm it was right. Medic made a great call. She did amazing. In fact, when she got to the hospital, the doctor at this Taj Mahal Cardiac Center said, what hospital did you come from? She goes, I didn't. Where'd you get the heparin? Oh, I gave it. I'm sorry? That's medicine. And people argue, we can't do that in urban America. Look at the numbers. New Orleans did a great study looking when the first time they got blood when they got to the hospital. The time they arrived at the hospital, the time they got blood. It's fascinating. It's not as quick as you think.
So here's what I'm going to say, Doc. I almost forgot that we were doing a podcast because I was about to ask you some more questions but I want to kind of go off of exactly what you just said right now, that people are saying, well, that only can happen in rural and urban. And I firmly believe that we've got to talk about reforming healthcare in general, not just EMS.
I agree.
But reforming healthcare in general through 2 different lenses, rural and all other markets. Because there are certain things that happen in rural. The conditions might be a little bit different, but there is still access points. There's longer times to get to hospitals. Sometimes you can't even get there by transport. They have to be helicopters.
Let me give you another example. So stockyards, right? For those of you that don't understand rural redneck medicine, that's where we sell cows, right?
Yeah.
And we've got a big one in my community, and it's a great family, and they've been doing it for a long time. And we have a lot of cow versus people in those events. And we realized that they have a very interesting bacterial infection when they break their bones. So we went and cultured the dirt. We found there's a very specific bacteria in the dirt. So now when we have an agriculture injury, we're adding in 2 grams of a very inexpensive antibiotic, $4, because the evidence says you need to have a washout in 6 hours. So what we did at Asbel was we took an IV bag with some betadine, and we did, and excuse my French, a redneck washout. And we're going to do it with every patient now that has open fracture in rural America. Every patient has agricultural injury in rural America. And what we found is the morbidity of those patients, not one has had an infection from post-op complications. Man. Now, is that coincidence? And the research people out there are probably flipping their heads now. I'm not academic. I don't have a force of 500 people to look at this stuff. I'm telling you real life numbers. It's there. And the stockyards believe in it so much, they're my number 1 donor of the blood program.
So this is the transformation that I know this administration is looking for that comes out of this Rural Health Transformation Program, Dr. Darsey. So the one thing about you, the reason why I have you here at my conference, because I'm a healthcare finance guy, is you understand the healthcare economics. You're not just a clinician. You're not just a transformative, disruptive guy, and you're making a lot of caveats saying I don't do academics anymore, whatever. I get it, but you do real life world experiences. Because I know we're going to have to be winding up here, but I have a few questions I want to ask you. I could sit and talk to you all day long. Talk to me about what do we need to do different in rural health America if we did not have any impediments of all these different rigorous regulations or whatever to make sure that healthcare got, by being still cost efficient, increasing quality of care, but I'm not tied to one vehicle or another to make things happen. Talk to me in Dr. Darsey's language what you would do.
So in rural healthcare right now, there's a lot of well-meaning people that are coming out of large academic centers, and they're preaching what rural healthcare needs. We don't need to be given something. We need to invest in something. Big difference. A lot of people are arguing telehealth, and it's great in certain circumstances. But you got to understand that we have folks that don't trust that want to see a real person in a real clinic. And so we have all these things are coming out, and all these big centers trying to do all this cool work. It's great, but they don't understand rural medicine. A great example, we have 2 types of rural hospitals. 3 really, but 2. Rural emergency hospitals, we'll talk about those in a second, maybe. You've got those that are owned and those that are independent. And you have so many of our hospitals now are buying smaller hospitals for a lot of reasons. But one of those reasons is to increase their catchment area. And so what we've gone from is a way of bringing people into local hospitals and trying to keep them there to bringing them in to them ship them out. And so from an EMS perspective, this really hits home in the rural emergency hospitals, is we bring people there knowing they're going to leave. And so if you look at rural healthcare, we've got to look at the lens of what can they sustain and what do they need, not to what we want to give them. It's a very patriarchal world right now with a lot of people saying they need. No. If you could provide 1 or 2 clinically competent people that can provide advice in a tort-protected area in certain states for rural health care, we would do more for rural health care than any telemedicine system out there. Because remember, those that are answering the telemedicine typically, and I was there for a long time, never worked in rural America. So I'd start saying things, and they looked at me like I had 5 heads. We don't have that here. We don't have that here. We don't have that here. But there are ways to do what I'm asking without having it there.
So you just said, you made some statements here, and my brain's swirling. Invest and sustain is kind of what I'm coming up with. You think that in rural health America, I'm just summing it up in 3 words, invest and sustain. What does that investment look like?
I think 3 things. 1, the investment is an emergency response system that is tailored to the community. What I mean by that is We got to have equality in 911 operations and layered understanding who gets what when, right? My state's a big private ambulance service, and other issues in our industries, we're all different in our state. So there's 55 or 60 different models that are out there. Our model is very much private-based, which is awesome. I work for one. They're great. But it changes the ballgame because it's first come, first serve. There is no real tiered system. We operate one that's okay. It's not great. But we can learn a lot from our rural friends in that. So 1, 911 equality. Number 2, what do you want as a community? Do you want clinicians taking care of patients, or do you want to move the patient? It's a fundamental question we've got to ask as communities.
That's a good question, Doc.
Do we want to move the patient, or do we want to take care of the patient? Because there's about, the refusals that I do, the vast majority of those are third-party calls. There's really not a catchment area there. But there's a good 30% of the calls in rural America that just need access. They don't need an emergency room. Name me another healthcare system that will always move someone to the highest level of cost and don't report quality. There's not out there. We're the lone survivor. And until we start talking about that concept, we will continue to be paying for diesel or jet fuel.
Well, Dr. Beck will love you. So I've talked a lot to Dr. Eric Beck. I don't know if you've met him before, but you have now. And he's all about the language of quality, and there's a lot of people talking about this. It's a very important observation for you.
We saw, and when we were doing aeromedical, we saw the quality come up, and we saw the angst and the frustrations and the pivots. But, I think the quality is there. And we got to look at quality as a longitudinal. We've got to understand, and I know there's a lot of people working on this, but when we do an intervention, what's the outcome of that? Not the clinical outcome necessarily, but what's the cost outcome? Great example, dialysis patients. Literally one change that could be made with our friends in government would be allow local hospitals to transfer a dialysis patient to their existing dialysis chair. We can't do it. So now a third of the patients that are in the system in my state, in the transfer system, a third, are only going because they happen to be on dialysis. Not that they need dialysis, they don't need emergent dialysis. They can be cared for locally, but they're being transferred just because they have dialysis.
So you're bringing up a point. There's a reason why I'm doing data, doctors, and leadership. For too long, it's been people like me that understand healthcare finance and policy sitting in rooms at tables. We're crafting legislation. You're working with healthcare economists, and nobody has it from the clinician's perspective because we can't answer questions like that. That makes sense because we don't have physicians
it's
at
a team.
the table. It's a team.
It's a team. It's got to be a team. And one of the things that, there's so many EMS physicians that just sign the sheet of paper, right? And the beauty of what we have crafted with such great groups of people is that this is a bi-directional conversation. Because I want to know when you call CPS of a child. I want to know when you have a hoarder. That's a solid determinant of health. We're the only people that see that every day. Maybe home health, but I love them to death, but they call 911 every 2 minutes, right? So now we have this opportunity to say yes, and I'm trying to get our guys to lean into that. That's a little harder, but when you see something, say something, to take the Homeland Security route, because we can fix some of this stuff.
Yeah. So I'm going to have to kind of shut this down. I have one more question for you. We're going to definitely do this again. We're going to have a round 2 because literally I could sit here and talk to you. Your perspective is so needed in the rural healthcare side of it. But I'm going to leave our audience with one question. What keeps Damon up at night?
You mean get real specific?
Yeah. Share what I really would like to know.
The Mississippi River. It's a beautiful river. You may not know this. You may, because you're a pretty travel savvy guy. 82,000 people traverse the Mississippi River every year on cruise ships. The average age, 85. There is no emergency plan if one of those boats was having an issue.
Really?
None. That's what keeps me up every night. That's what rolls around in my head of things that I cannot impact that is a real threat. And I say that for people to understand that we all hear about bad things in urban America. But every night, one of my communities has an event that stresses the system to the max. And the true version of healthcare, in my humble opinion, is the guy that can roll out of bed, go to a scene that's unknown, handle it, almost by him or herself, get back in and go home and go back to sleep.
Dr. Darsey, thanks for this conversation.
Yeah, it's been
Number
fun.
one, thank you
Yeah,
for what you do
I
in
obviously
rural
didn't dress
health.
nearly as nice as you do, but it's
thank
fun.
you. Thank you so much for what you're doing in rural
It's
health
good.
and
We got a
continuing to
great
lead this
team.
conversation
We
forward.
have a great team.
Appreciate you.
Yes, sir.
Thanks for joining.
Yep.
You bet.